Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is Jill Jin, Senior Physician Advisor at the AMA, and I am your host for today. So today we're discussing a topic that I am sure is important to every single working person, but especially for physicians, and that is time off from work, or PTO. And I'm joined by Dr. Diane Shannon, a primary care physician, physician coach, burnout consultant, and my co-author in the AMA Steps Forward Toolkit, Real PTO for Physicians, Reducing Barriers to Taking Time Off. So welcome, Dr. Shannon, and thank you so much for being here today.
Thank you so much, Jill. I am thrilled to be here and talk about such an important topic for physicians.
So before we get started, could you tell listeners a little bit more about yourself and your background and how you got into this physician coaching space?
Yeah, so interestingly, I have had 3 careers in my life so far. The first was as a primary care physician, and I experienced burnout in residency, but I said to myself, I am going to finish and I'm going to take my boards, passed my internal medicine boards, practiced for a few years, and was not severely burned out when I made the decision to leave clinical practice, but I didn't have the knowledge or the skills or the support to figure out how to create a sustainable career for the long term. And I saw that. So I made the decision to move into writing. I was a medical director at a communications company for 3 years, and then realized I really loved writing, and it came to me fairly easily. And so I transitioned into freelance and was a freelance healthcare writer for about 20 years, writing for the AMA and also for National Patient Safety Foundation, the Institute for Healthcare Improvement, some consulting companies, all of whom were looking at how do we improve our healthcare system. And it really gave me a sense of the factors that are at play for physicians and for patients. Then I stumbled across the definition of professional burnout. I had no idea what it was before I was a writer for several years, and realized that it was something I really cared about addressing this for others. And I was lucky enough to work with another physician to write a book about how to prevent this based on the system factors that drive physician burnout. So it wasn't really thinking about the individual, but more about the system and how do we change all of those pressures that physicians are under that increase the risk of burnout. As part of that, I was inspired to become a coach when I saw another physician who was working with groups of his colleagues and using coaching to help them regain the bandwidth to be thriving themselves, but also to then take that energy back to their organization and help to improve some of the system factors. So today I am coaching full time, and my focus is really helping physicians create sustainable careers using the skills and knowledge and support that I wish I'd had back then. So I've kind of come full circle, and I use everything that I've learned over the decades to do what I do today.
That's so wonderful. And yeah, I think you just described our entire philosophy and goal at AMA Steps Forward. And coaching, of course, is one of the actual proven interventions, right? Proven by randomized controlled trial data, which is not common in this field of burnout, to actually help reduce burnout and turnover. So thank you for all that work that you do. But let's dive in more specifically into PTO. I guess I'll start off with a study that was published earlier this year in JAMA Network Open. It was a survey-based study that surveyed several thousand U.S. physicians across multiple organizations and specialties and looked specifically at PTO and how much PTO physicians were taking, and among those who were versus were not taking it, what their burnout rates were. And of course, it found that those physicians who took less PTO had a higher rate of burnout. So there is a direct link, which was it makes sense to us logically, but it was nice to get this data to support that. So in that study, and then from other survey data that is out there, we know that physicians are not taking much PTO. So they're typically allotted probably 5 to 8 weeks of PTO each year. Some of that is vacation, and some of that is, sick time. Some of that is CME, continuing medical education. But most physicians do not take their full amount of PTO. And in the study I just referenced, approximately 60% of physicians reported taking 15 or fewer vacation days per year, and then 20% took 5 or fewer days per year. So clearly this is a problem. Physicians are not taking their time off. Why is that the case?
Yes. And I want to start just with a quote that's in the toolkit from one of the physician leaders that I interviewed. And he said one of the administrators had come to him and said, can you please get your people to fill out their timesheets or whatever the equivalent is for taking PTO? It's like, they're not filling them out. And we really need this data. And so he went and he talked to the physicians in his department. And what he found was they weren't taking vacation, right? It wasn't that they weren't reporting it. They weren't taking it. A big piece of it is that there isn't, in many organizations, sufficient coverage for when they're away, especially the inbox messaging, right? So they're getting continual messages while they're away, and then they know what they're coming back to. And that is overwhelming. Some of them are literally contacted while they're on, quote, vacation. So that gives them a feeling that they're not truly off, right? The other piece has to do with the finances. And if they are paid by productivity or based on productivity, and that productivity calculation is based on 52 weeks a year, there is a disincentive to take any time off because you are, quote, losing money. So a piece of that is that built-in disincentive. And I would say with some of the clients I've worked with, when they describe trying to make decisions about taking time off, they say it's kind of a black box. Like, I really can't figure out how I'm doing mid-year in terms of the productivity numbers. It is so complicated. I don't know what the impact is going to be if I take 2-3 weeks off. And so I'm hesitant to do that. So there's a piece of it that is not having that clarity about what the financial impact will be. And then there's the true financial impact. The other piece is that, we do have in medicine this culture that says self-sacrifice is an important part of our identity and that we need to be available all the time. And I remember, in training, there's this kind of bravado about being tired, working more, being available. When that's infused in our culture and in our training, it does make it more difficult to step away and let ourselves get that recharge time that we really need.
Yes. Those 3 key components that you touched on, I guess it would be the 1 is the finances, 2 is the inbox coverage, and 3, the culture. Definitely want to get into each one of those. But let's kind of first talk about, that the title of the toolkit was Real PTO for Physicians. And you mentioned how many physicians, when they're off, they're still being contacted, they're still being paged, and they're getting emails about work. So it's not actual time off. So, and I think in the toolkit, we use the quote, PTO as standing for pretend time off, which is, the opposite of real PTO. So what we're striving for is the opposite of pretend time off and actually getting from pretend time off to real PTO. So what does that look like for you? Or what do you think real PTO should be in an ideal world?
I think what real PTO is, it is truly protected time where an individual can be off and not be contacted, not feel guilty about the time they're taking off, not worry about the impact that's having on their colleagues. And when they return, they are returning with an kind of an onboarding or kind of re-entry process that is something that doesn't take away what they just received in terms of recharging. And one of my clients said, it takes away all the zen of vacation when you come back and you're starting day one full time back in there, and you've got this enormous backload of work that you have to kind of somehow find your way through to create extra time in your day to catch up. And it is such a disincentive to taking time. The other thing that I just want to mention in talking with some of my clients as I was writing this piece, I was really struck by the level of anger about this topic, that many feel they've been duped because in their contracts, it may say you have 8 or X number of weeks of PTO, but when they actually go to take it, it's another story, meaning the guilt, the difficulty scheduling it, the anticipating what it's going to be like coming back. And it just doesn't feel worth it. But to be told in your contract, you have this time, and then the reality is something very different.
Yeah, exactly. The disconnect between what the actual physicians are experiencing versus, right, the administrator saying, hey, look, you have this time, the person who is saying, why aren't people taking, why aren't they recording it, right? So let's talk about those, again, those three components, the culture, the financials, and the patient care coverage. I think let's start with culture because that's such a big part of medicine, as you're saying, and arguably the hardest thing to change, right? Is how do we get around this culture of self-sacrifice and feeling like it's your calling and your duty to be on all the time and still taking care of patients and never taking time off for yourself? What can we do?
I would say, changing organizational or professional culture is challenging. It's not going to happen overnight. I think one of the most important things that we talk about in the toolkit is modeling, is that leaders are modeling taking time off and celebrating that. And there's so much that says about what those that they lead can do. It normalizes taking time away. And so I think having more of that both modeled and in the conversation is really important. I think the other piece of that is when a physician is off, they need to be really off, meaning the leader and other colleagues, how they communicate with that person when they're on, quote, PTO or vacation, whatever. So are they sending emails to that person while they're on vacation? Or are they scheduling them so that they do not arrive while the person is off? And the same for nights and weekends. It may benefit an individual to do their replies to emails or create emails in the evenings or on weekends or 3 a.m. That's their choice. But the person receiving that, if they're receiving it from a leader, they may feel this message that says, you should be on, you should be working all the time. So instead of doing that, either including in the automatic, email signature, something about not needing to reply if it's off hours, or even better, scheduling that email, that communication to go during regular work hours. So those sorts of things do send a message, and I think that's important in changing the culture. The other thing I think is really important is proactively blocking in physicians' schedule templates time for vacation. So that could mean at the beginning of a year, blocking time, even if the physician hasn't decided exactly when that vacation is going to be, putting holds in there. They can be moved. But that says we expect that you are going to take time off. And so again, that begins to change the culture.
Yeah. Yeah. I think that's so true. It's sometimes I feel like people just give up because they're saying, oh, that's medicine. That's the professional culture will never change and there's nothing we can do about it. But like you just described, there's sometimes little, small, concrete things actually send a big message. And I would argue that actually that email signature at the bottom saying don't respond during your time off is not enough because people will still respond, but it's actually taking that extra step to schedule the send. If you're talking about changing the culture of the organization, which ultimately reduces burnout and keeps your physicians happy and working and more productive, then it is your job to do those little things, right? Yeah. Yeah. Do you have any examples of organizations that have done this work and have created a more positive culture?
Yes and no. I would say I've spoken with clients who are leaders of departments that have made changes. I'm not sure the whole organization has bought into that yet. But I do think that there are some that are beginning to recognize how important this is and to make some of those changes. I think one of the hard things about doing the research for this toolkit was that I didn't find any organizations that had it quite right yet. And there is the interest, and I think there's the beginning of really recognizing that. And I would say too, knowing how many physicians are experiencing burnout, how many have left the profession or left their position at a particular organization in the past couple of years, like that turnover, that it is becoming more and more important to address these underlying drivers of burnout. And not having enough recharge time is definitely one of them.
Yeah, absolutely. Okay, so let's talk about the coverage piece. And you mentioned the coverage for the EHR in basket, which of course is a huge part of it. And then there's just the patient care coverage, who's going to see patients who get sick and things like that. So that again is a huge challenge because I think in most places, most practices, if you take a time off, the burden is going to fall upon your colleagues, which is also, we don't want to burden our colleagues. There's the guilt about that. So what solutions are available or out there for this problem?
Well, the first I would say is that it does in some instances depend on the model that people decide to use for inbox coverage. And there are different models, and there's a table in the toolkit that goes through different potential models. So that might be using a physician assistant or nurse practitioner to do some of that. It might be to increase the triage of those messages. Also going upstream, and this is a different toolkit that the AMA has, but going upstream to reduce the number of messages coming in total, right? So that there are fewer to deal with when a person is on PTO. Really having a policy and seeing this as this is the organization's responsibility to address these inbox messages. It is not the responsibility solely of that individual physician. And why is that? Well, first of all, we know that the number of inbox messages has soared in the past 4 years. It is more than any individual can handle. And it's an important aspect since the pandemic, with more and more patients using this modality of communication, it is an important part of patient care. So it needs to be recognized and really given the priority of a policy that makes sure that there is triage and coverage, including coverage when a physician is away.
I do think that is the key point is, of course, there's going to be different models based on the subspecialty and the patient population and, and staffing, et cetera. But the key point is that this is the organization's responsibility, right? To figure it out, to hire the NP to cover, or to either hire a locum to, for physician to physician coverage. But it cannot be something that each physician who takes time off has to figure out on their own. They can't be the ones who are left to solve this problem and ask their colleagues and for a favor and feel like then they owe them in return. That in itself is such a barrier to taking time off. So the organization needs to build this extra coverage into their staffing model, their financial model.
Jill, one other thing I want to mention there, and this comes from years ago, probably a decade ago, Mark Linzer, who is at Hennepin County Medical Center and was the developer of the Mini-Z burnout inventory. He said to me, I was interviewing him for something, and he's also served as a mentor for me over the years. And he said, we can anticipate that there's going to be a certain number of physicians out for various reasons. It is not a black box. It is not something that is unknown. We know this is going to happen. We need to plan for it. So in other words, let's say it's 10%. Instead of hiring for 100%, you hire for 110. And then you have enough coverage for those anticipated times away, whether that is medical leave, parental leave, bereavement, or vacation, right? Though we can anticipate that. And until he said that, I had never thought about it that way, that this is not an unexpected thing that happens. We can calculate for this and plan for it.
Yes, exactly. Okay. And then finally, the finances, that financial piece. And so, of course, this gets very complicated and there's different compensation models. But I think what you mentioned at the beginning that really struck me was the black box, right? There's just no transparency and clarity about how taking time off affects your compensation, that people are just too scared to do it. And that is actually the key problem, I think, the lack of transparency. So if you ask, your HR person or your administrator about paid time off, they'll say, yeah, physicians are getting paid for their time off, right? They're still getting their paycheck every 2 weeks or, however often they get there, but it's still happening. Even when they take vacation, they are still getting paid. So why do physicians feel like they're not getting paid for their time off? I think there's two issues with that. One is productivity thresholds, the bonus thresholds being based on 52 weeks and not 46 or 44 weeks. So it becomes unrealistic if you're basing it on 52 weeks and not taking the vacation time into account. And then second is that piece of transparency. They just don't know. They don't know what taking time off is going to do. So they feel like they cannot take time off because they're not being paid for that time. So what do you think can be done to help with both parts, the transparency part and the realistic expectations in terms of RVU productivity?
Well, that lack of transparency really is a problem. And it does make it more difficult when the compensation is based on productivity, because that fluctuates, right? Versus it being flat salary. That's a lot easier to calculate. And physicians being paid a salary without the bonus and productivity based compensation, they're still dealing with the issues around taking time off, but it's not directly tied to finance and that lack of transparency about what is this going to do to my paycheck or my bonus at the end of the year if I take this time off. One of my clients was telling me that in her organization, if you try to take more than 1 week at a time, because of how the look back is for the compensation model, you will be dinged if you take more than 1 week in a quarter. What if you want to take 2 weeks to do something in particular? So I think it's a matter of really physicians vocalizing that this is important. It's very hard for one person to get their contract changed. But if a number of physicians are saying, hey, we want more transparency about what this means in terms of our taking time off, that might be effective in getting some change. But again, it is complicated. That's the problem with the compensation model, and therefore it's hard to get a sense of what the impact is going to be of taking time off. I think the other piece is that this is something that you're going to be able to advocate for much easier in a group versus one-on-one trying to advocate for more transparency.
Right. And I guess I don't know of any organizations that do this, but for a specific practice, if you just looked at what a realistic number of RVUs per week would be, and having the quote unquote bonus threshold being based on that number times 44 weeks, instead of the 52, that seems like a reasonable solution to me, right? I think that seems doable, but I guess it's just hard when all the numbers organizations have are based on, MGMA or those kinds of national RVU data, which don't take PTO into account. That's just however much physicians are working, at the end of the day, which is more than the suggested PTO.
Right. Well, and what I like to think about is right now with the environment as it is, meaning it's getting harder and harder to find physicians to replace those who have left the organization or the practice or whatever, or the region. This is the time when organizations who do this right are going to be attracting more candidates and candidates who are going to stay. And so I think this is where it really takes a little bit looking ahead, not just thinking about this quarter's finance, like for any organization looking ahead, but this is where an organization whose leaders really embrace this of like, how can we retain and help physicians to thrive and solve some of these problems around PTO? They could have a really vibrant, loyal physician workforce.
Yeah. Yeah, I absolutely Agree with that. And I think, in all our burnout calculators, we kind of use the estimate of to replace a physician costs $500,000. But of course, there's more recent data that suggests it's actually even higher or much higher than that. So just thinking about that, I think it's hard to kind of recognize the business case, but it is there. We have the data to support it, right? We know that not taking PTO is linked to burnout based on that study I mentioned at the beginning that was just published in JAMA Network Open. We know that burnout is linked with leaving the organization and turnover, and we know that turnover is costly. So it's a matter of recognizing that this upfront cost of either hiring, more coverage or reducing those bonus thresholds, these costs upfront are worth it, right? They'll change in terms of the payoff, in terms of the culture change, as well as ultimately the retention rate.
Absolutely. And the other piece, some of the softer numbers in terms of patient access and patient experience, right, will also be improved if you've got a stable workforce. The one other thing I wanted to mention, this came up so many times with my clients when they talk about this topic, is around guilt. The guilt that they feel and the values conflict that comes up in two places. One is about, if I take time off, now my colleagues have to cover, right? So the guilt about that. Then the guilt about patient access. If I take time off, I already have a 3 or 6 month delay before anyone can get in to see me. Now it's going to be worse. Or what about that patient who really needs to be seen next week and I'm going to be away? So that really causes a lot of psychological distress, that sense of guilt and the sense that if I take care of myself, I'm harming someone else. So there is that moral distress that comes up. And I really hadn't thought about that before until I really started these conversations with some of my clients about the depth of that, the pressure and guilt that they feel about just trying to take care of themselves. And the truth is that if you experience severe burnout and need to take medical leave, need to leave the profession, leave the job, whatever it is, you are going to be even less accessible to patients. And so building up whatever it is that you need, the scaffolding to keep you in a place where you can be at your best, is the best move for everybody.
Yes, absolutely. Okay, so any other pearls of wisdom that you'd like to share today on this topic?
Yes, there's one concept that I've been thinking a lot about, and this applies both to real PTO, but also to other aspects of fixing kind of what's broken in our workplace. And that is that little adjustments in what we do can have a huge impact. And this is something that has surprised me over and over again in coaching, that my clients will make a series of very small changes and suddenly their work experience is totally transformed. So I think that idea that it can look daunting and too big and I'm never going to change this, but just starting with very small changes can make a huge difference.
Yeah. Great note to end on. It's never futile, right? I think there's always something small that we can do that makes a big difference. Well, thank you so much, Dr. Shannon, for being here today and for offering all your personal insight and wisdom. And we appreciate everything that you're doing for our physician colleagues.
Thank you so much for having me.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.